Good afternoon, everybody, and welcome to this event at the Harvard Chan Studio. My name is Wafai Fawzi, and I am a professor of global health, nutrition, and epidemiology here at the Harvard T.H. Chan School of Public Health. Really excited to have this event with our esteemed colleagues, two ministers of health discussing the elements of transforming women's health in Africa. Welcome to Lia Tadesse, who is the former Minister of Health in the Federal Democratic Republic of Ethiopia, who we're very fortunate has been recently appointed as the Executive Director of the Harvard Ministerial program here at the School of Public Health, and a member of our faculty at the school as well. Welcome, Lia. And to Minister Coll, who served as a minister in the presidency of the Republic of Senegal until recently, and previously served as Minister of Health for 2 terms. We're very pleased that she is now here at the school as the Menschel Senior Leadership Fellow at the T.H. Chan School of Public Health, teaching a course on leadership, and I hear from our students that it's a very popular course, so thank you so much, Awa. We will cover elements around women's health with a focus on Africa, and we are so fortunate to have 2 leaders in this field. And maybe we could start sort of with a big picture, if I may, asking you both with your perspective on where are the challenges in women's health in Africa today. There clearly has been a lot of progress over the last 2 to 3 decades, but still many challenges remain, from maternal mortality to infectious diseases, HIV and TB and malaria, malnutrition and others. So, Lia, if I could start with you, if we could sort of leave today with an understanding of what are the major challenges affecting women's health in Ethiopia and in Africa at large, what would that be?
Thank you very much, Wafai, and thank you for having me here at the Chan Studio to discuss this important topic. And indeed, women in Africa still face significant challenges in terms of women's health. Yes, we have come a long way in terms of improvements in women's health, both as a global community, but also in our individual countries. But there are significant challenges, and the key one that we always prioritize is, of course, reproductive health, which rightly so, because we have come significantly a long way in terms of reducing maternal mortality, increasing access to family planning, which is also one of the most effective interventions in terms of reducing maternal and infant mortality in countries like mine. Ethiopia had a very low contraceptive prevalence rate around in 2000, which rose from about 8% to now about 40% of contraceptive prevalence rate, which had significantly impacted the women's ability to space and then reduce morbidity, mortality, and also has impact on the economic empowerment of women. But still, we are a long way to go in terms of ensuring unmet need, access to family planning services, and the quality of family planning services that we provide. And although this is a big priority in terms of reproductive health, one thing I would like to highlight is that when we talk about women's health, there is significant challenge that now women are facing outside of reproductive health. So when we think about NCDs, there's huge disproportionately affecting women in terms of, if we take cancer, obviously the cervical cancer, breast cancer, we have very high burden in our countries because of the obvious reasons of inadequate access from screening to treatment, but also issues like hypertension, heart diseases, diabetes now affect large number of women. In fact, if you see the proportion of diseases that impact women, these are larger than the reproductive health issues. So I think one of the things I would like to really emphasize is when we think about women's health and what women are facing, we need to think about the holistic approach of what we provide in terms of from primary care up to the different levels of care in terms of really having integrated services. And that's why for Ethiopia we have recently been focusing on really decentralizing care of NCDs in primary health care to ensure we have access to screening through VIA for cervical cancer and treatment to precancerous lesions, and also access to basic hypertension, diabetes screening and services at primary health care level.
Mm-hmm. That's very helpful. So there is this notion that we always think about maternal mortality as the primary, and reproductive health is central to that. And then with the epidemiologic transition, thinking about NCDs is really important. But maybe, Awa, if I could ask you, from the perspective of infectious diseases, you served as head of rollback malaria and in a senior position with UNAIDS around HIV. There is a sense that these are still problems. Is that fair to say, or have we sort of solved most of that and we need to focus mostly on NCDs at this point?
Thank you, and happy to be with you. I would like to say that we have what we call an unfinished agenda, which is the agenda of infectious diseases, maternal mortality, and so on. But also, what she has said, it is important not to be focused only on that, but we need to look at other type of diseases and problems. It is why I would like us to have very clear in our minds that we need to look at an holistic approach, but also a comprehensive one, to ensure that we are tackling all the challenges which are multisectorial. And we need to ensure that all the sectors are involved if we want really to take care of women's health. It is not just the Ministry of Health or the Ministry of Women, but you have a lot of issues like empowerment of women, gender, way to look at it, and this needs really an holistic and multisectorial approach. Looking at HIV, AIDS, and malaria, we also have still problems there. If I look at some issues like access to care, access to treatment, access first to testing and diagnostics, it is difficult for women to have particularly access when it is HIV. How you will go and ask for a test if your husband, your partner, the people you are in your community are maybe not allowing you to do that, because this is a difficult thing after to negotiate. Access to healthcare is important, and we need to ensure that all the structures are in place for women. You have also the issue of maybe discrimination. I take the other one. If you take again HIV, you are a woman, you want to do a test, you have to go through all this negotiation maybe internally, but when you have to come back with a positive test, people always, because of cultural behavior, etc., will look at it as what she has done. And often you have a lot of discrimination and stigmatization. Another example could be the example of having to look at reproductive health. When you are pregnant, particularly, and you have malaria, you are at risk to lose your child, and you are at risk to also to have premature child. You can have also very low possibility of having a strong baby, because it has not the wealth people need to have. And when you look at all this, you look at also the issue of HIV. You can transmit the virus to your child, and during your pregnancy, at childbirth, but also when you are breastfeeding. All these are specific things you can have when you are a woman. And I want also to highlight what we have in this difficult situation is often because of challenges need to cultural norms, but also sometimes geographical distances. And you can have also a lack of empowerment of women financially, because she cannot go to do things because maybe she don't have money or she has to wait for the husband to do that. So it's a complex issue. HIV, AIDS, and malaria are maybe some specifics we can put on the table, but it is more global, and it is why I am very much supporting the intervention of Minister Lia, because at the end of the day, it will need a comprehensive approach and not only looking at HIV, malaria, but look also at all the other diseases.
That's really helpful. So many cultural factors to contend with and health system elements to strengthen diagnostics and capacity to reach women. Helpful background from both of you. If I could just transition to thinking a little bit more about what does that mean really, how to address these challenges that we have just heard about, particularly from the perspective of reforming and informing policies in ways that are evidence-based. You both have led really massive programs in your respective countries and had influence beyond your countries in seeking how evidence is put into policies and how these policies are translated into programs to address population health and women health in particular. So I wonder, Lia, if you could comment on your experience with how that has been possible to sort of weave elements of women's rights, some of the concerns that Awa has mentioned, into health policy. How were sort of policies addressing women and girls' rights possible to embed into programs that you have advanced?
Thank you so much. Yes, the type of policies that we implement influence the outcomes, and especially the evidence-driven policies that we make. And when we think of women's health and women's rights and empowerment of women, of course, we need multiple layers of interventions. But I think one single very important one that has been impactful is education. So the girls' education, ensuring access from primary to different levels of education for girls has been a key contributor. When we see the impact in our maternal mortality, those who have been educated would have higher likelihood of using those contraceptives, or also utilizing care and giving better care to their children as well. So that has been one of the key factors that we have been pushing as a human capital development agenda as well. And although we're still, again, a long way to go, we have increased from about as low as 21% of primary education enrollment for girls that has gone up to 90%. But when you go to high school, still we have huge dropout of girls as compared to boys. And the other related to that, related to the education, is the engagement of women in the workforce, having that clear policy as well. So when you look at our community health extension program, it intentionally uses women to reach communities and families. And that has had a significant impact. Well, they are there because they were educated in the first place, because we take high school graduates and then train them for a year. And then, but because they are women and relating to families in the urban, in the rural communities, that had made the access to the services they provide more acceptable by communities, bringing impact. So I think that's one key one. But I think I want to highlight a second one quickly, is when women face many barriers and obstacles to health care. And one of the key ones is the financial barriers that women face. And the commitment, a policy level commitment to universal health coverage, especially ensuring financial protection, has been one of the key issues that has been we have seen in my role as a leader as well. So we have been implementing community-based health insurance, which targets the rural, mostly rural or informal sector, which accounts for the largest population that we have. And because now women are having that, are enrolled in community-based health insurance, there is more utilization, more empowerment, because they make decisions for themselves without waiting to get the money from their partners, their spouses, and we have documented this from the studies we've done, and really ensuring that protection, financial protection for women at a policy level has really shown impact in terms of really enhancing access. So policy level decisions are really crucial with political commitment to ensure progress in women's health.
It's really very helpful. Education, engaging them as workers in the workforce, and commitment of financial resources are critical. Awa, if I could ask you back to your point earlier about cultural factors, how, when you served as the lead, one of the lead commissioners on the Lancet Guttmacher Commission around reproductive health rights, sexual and reproductive health and rights, what's your experience from that and from your experience as minister in ways to sort of address these cultural barriers that you referred to earlier, and how these are harder to change perhaps? I mean, it's hard to find resources, but it's also hard to change culture in a way that is more conducive to women's health.
I have a concrete example, is the one of introducing HPV vaccines at school. We all know that HPV is at the beginning of this journey to arrive to cancer. And when you have this type of cancer, of uterus cancer, you have this big challenge of having access to care, suffering, dying, etc. And all the world has been very happy to see that if you can vaccine your girl, you can avoid this to happen. But when you are vaccinating a girl of 10 years old, the cultural beliefs is very clear, and religious beliefs also, that at 10 years old you vaccine somebody, this is just open the door to go and have sex. And this can be a big problem. It's not only in Africa, it's I think in other countries too, but more maybe in our continent where you have a lot of pressure culturally. But we had a strategy, first of all, to put it as a policy in our plan, but also to have a very inclusive way to do that, to implement it. And working with parents, working with religious leaders, working with also traditional leaders, women groups, and all these groups, we can have an influence to put it not in the part of sexual and reproductive way for young girl to behave, but to put it as a prevention for cancer. And by doing that, finally, we have been able to pilot it first and look at what will be the reactions. And we finally have the parents themselves very happy and agreeing to put it on their own agenda. But they wanted also people to be clear on campaigning for young girls. It is not because you have the vaccine that now you need to go to be sexually active. You can also just stay and wait for the time you see your partner you want and your marriage. It's possible, but it is very clear that it is not forcing them to have to to be sexually active. This is just an example, but you have many examples I can use, but for the time I will stop here.
Great, thank you so much, Awa. Definitely engaging all stakeholders. You mentioned religious leaders, you mentioned the parents themselves, and sort of getting them to buy into the idea. And it's not just a sexual program, sexual health program, but cancer prevention is a very, very good example. But transitioning to a related point, if I could ask you, Lia, many of these issues affect and engage with multiple sectors. And Awa mentioned earlier the importance of having multisectoral approaches. If we think about girls' health or women's health or even child health, lots of progress in Ethiopia, but still Ethiopia is one of the top 5 countries where child mortality is highest. Maybe it's population size, but also the burden is quite substantial compared to other settings. How have you been, and I know this is something that you have particularly championed in Ethiopia, how have you been able to engage other sectors beyond health, education, agriculture, to bring these elements together in a way that is coordinated and effective?
Thank you, and this is really fundamental in terms of how we make progress in the ambitions we have. Multisectoral coordination, collaboration, intentional one is really key, but always easier said than done. But yes, in terms of especially issues like child mortality for Ethiopia, we've had huge progress indeed. If you see the MDG time from 2000 to 2015, we had a decline of about 56%, and this was more attributed to the interventions we had at the primary health care level, from the health extension program up to the different layers of primary health care, including access to immunization and basic care and treatment for pneumonia, diarrheal diseases, and nutrition. So there were significant declines in malnutrition and mortality, but still very high. I mean, if you see the stunting rate, it declined from about 50% to 37%, but still 37% is a huge number when you look at the population size of the under 5. So to really drive progress, especially once you have the relatively lower hanging fruits, and that's where really the multisectoral coordination and collaboration becomes crucial. So one example I would highlight is how we were driving the agenda of nutrition or malnutrition as multisectoral coordination efforts, because nutrition is a very good example where health sector cannot really bring significant change without the engagement and collaboration with agriculture, water, energy, education, gender, and these are key sectors that are need to drive that progress. Well, unfortunately, when we are structured, we usually have our silos. So initially, but the government in 2016 made a commitment called Sakota Declaration to end stunting by 2030 for under 2 years. And the aim of this was to have a multisectoral effort to implement in very high stunting selected districts into regions. That's how we started. So but in few years we saw we were not really making progress, and we redesigned our approach to come from bottom up, where we have one plan which focuses on the district's priorities. So we invest in those priorities collectively, those different sectors. If the major challenge is water access for that community, then we prioritize that because it will impact the nutrition of that community. But of course we used those multiple interventions, but through one plan, one budget, and following the implementation as sector. So in those districts we saw a decline of stunting of 3% per year in the intervention years we've had, which was really higher than what we are doing in other parts. So we're trying to scale this up. So I think this is a very good example, but we still need to do a lot more in terms of coordination.
Lots of lessons from Ethiopia on this front, really. And Thank you so much for sharing that. Awa, if I could transition to ask you about another commission that you are involved in. You co-lead with Professor Muhammad Pate the Future of Health and Economic Resilience in Africa. It's a Lancet commission that has been really looking at the future. Many challenges, some solutions, some opportunities that could be scaled up. I wonder if you could briefly share with us what is FERA, as it's known for short, and how does it inform the future of women's health in Africa?
I would like first of all to thank Dr. Mohamed Pate, who was in Harvard when this started and is now Minister of Health in Nigeria, who asked me to come and be co-chair with him. But it is really the one who has been at the beginning of all these initiatives. Looking at FERA, he called all the experts who have been very, very productive in health in Africa in general, but also linking health to economic growth or economic issues and resilience in Africa. And you are part of those because you are the one in charge of the working group on, I think, nutrition, because we had several working groups and all these working groups was focusing on something. Personally, out of being the co-chair, I was in the working group looking at sexual and reproductive health for women, but also in the working group on the Sahel. How countries with instabilities can look at their future, looking at health. But women has a very important place there. And when we look at one of the first points, which was the holistic approach, we need to ensure that when we are looking at health, we are not looking at health, and I am repeating it often, like a medical health, but more broad. And particularly when we look at determinants, because when you have as a determinant nutrition, you can have empowerment of women, which is needed. You can have education, all these things. You can have also access, because it is geographic access, which is not good. You have to look at a broad way and not to look just at the infrastructure and things like that. Another point which is very important for women was the issue of universal health coverage. Because we know, and you have said that already, that when you have this access to services, because this is one important point, but increased population will have this access and decrease the very important burden, financial burden, you can be on the way to go to universal health coverage. And the first who are really happy with that are the women, because they are the one in charge of care in the family. They are the one who have a lot of specific issues looking at care, like pregnancy, but others also. I think that this was also a very important point on which but we put also very clear the issue of gender response, with empowering women, education. We say that also when you are educated, you have better health, and you have also the time and the knowledge to make choices and to help your community. And this is also another point. And the last, I want to, just not to take too long again, but it seems to me that one of the important points was not linked to health itself, but how to empower financially women and help them to be able to overcome some laws, very restrictive, like law in abortion. In Senegal, we have been pushing, because I am a member also of the Women Doctors Association, and we were fighting to say, if you don't want abortion in general, at least accept for incest or sexual abuse. but it is not done yet. But it is still something we have to. And the FERA has highlighted also this type of laws people need to look at to protect women and protect them also. The decision making also process is important. They need to be in position they can take decisions. And by taking decisions themselves, well educated and empowered financially, they will change everything in the health of themselves, but also their community.
That's amazing. Thank you so much, Awa. We are at about time, but I want to ask at least one last question, and if you can be brief a little bit. We talked a lot about empowering women themselves, which is important. And I want to sort of come back to empowering women leaders. Both of you are women transformational leaders in many ways that we have just heard a glimpse of in the past few minutes. Sort of thinking about the next generation of women leaders. Some of them are here with us today or listening to us online. What would be one or two pieces of advice that you have for them to be better prepared to lead? And I'm sure this could take much longer than you have, but maybe I'll start with you, Lia.
Yes, thank you. Well, one of the key issues, I think, is to always know that we are able and be prepared for the opportunities that come our way. One of the challenges, well, as women leaders, we need to really be mentoring and also supporting other women, young women, to come to leadership because there are so many obstacles women face, even if they have all the skills, all the potential. So mentorship is a key quality, I think, that we need to always cultivate. But a lot of time we set very high expectations for ourselves. That's what I have faced when I was trying to recruit women leaders for different leadership positions. They either try to avoid it because, of course, because they feel more responsible for what they're doing for their families, but also they set very high expectations for themselves and would say, I'm not sure I will be able to do this, but to know that they are able is really key.
That's helpful.
The time, quickly.
Yes.
Be resilient. Because you will have a lot of obstacles. Sometimes you will fail, but just start again. And being resilient, because nobody will give you everything like this. You need to fight for that. But don't say it is difficult, I cannot, all these things. It is possible. You have the education, particularly those I am seeing here. It's just to be resilient and be ready to go far. With your objective, you need to have it always in mind. The second is networking, as you said. It is good to know that other women are there and are ready to help. And they can accompany you, but also help you in your project, etc. And particularly network of women to be there is also important to ensure that we are not alone. My last point will be yourself. We are not men, we are women. Why we cannot stay women? We are women. Let's do what I can say God has given to us, which is to be a woman and to have a very important place in our society. We cannot be leaders and we now are like a man. No, I think we stay like we are, and we always think that we can do it and it is possible.
That's excellent advice for future women leaders. I say for future men leaders as well. Good advice. Be yourself, be resilient, and network with others and be open to mentorship. this has been really informative session. Thank you so much, Minister Lia, Minister Awa. You've both been role models, lots of experiences that you've shared with us in this brief time. So delighted that you are part of our community, and I look forward to continuing our engagement with you for many years to come. I'd like to thank also the audience here and online, and many thanks on behalf of the Harvard Chance Studio to everybody who has joined us today. Thank you so much.
Thank you.